Hello.
Yes, sir.
Yes. Am I audible, sir?
Yes, sir.
So, Dr. Satish Jain this side,
Yeah, sir. This is Dr. Shoban coordinating from the auditorium, sir.
sir. So nice. So, first of all, I would like to pay my regards to the organizing team of the Telangana state, especially our president, the organizing chairman, Dr. Ramanachari, and the secretary, Dr. Sai Prasad, for giving me this opportunity to be here to share a small experience with you all. And what a fantastic facilities here in the theater with multiple cases, planned for demonstration. So
Sir.
the first case which I am going to start, want to share some radiology with you. Are you getting any MRI pictures over
Yeah,
there?
we are getting, sir, the coronal cuts.
Yeah. So basically, this patient had a history of trauma, and CSF, the watery discharge from the nose, for which the scan was done since it was post-traumatic, assuming a CSF rhinorrhea, and we have direct MRI pictures of the patient. And what we see on MRI, see if you go from anterior to posterior, this is simple T2 weighted MRI, and what you see here, some opacity coming. Can you see this?
Yes.
In the posterior part of the ethmoids, continuing in the sphenoid, and see in continuity the contents of the brain or the brain tissue is herniating down in the sphenoid together. Can you see this?
Yes.
So that's a classical picture of a meningoencephalocele, you can say.
Okay.
This is T2 weighted picture. Now we have a drive image as well. Drive is much better. You have fine section, 1.2 mm section. And what we see here, see this hyper intense opacity of CSF. The
Yes.
fluid. See the intensity of CSF and the same intensity over there, and that too in the continuity. See this?
Yes.
So this is undoubtedly a case of meningoencephalocele with CSF leak, and that is too anterior in the roof of the sphenoid through the plenum sphenoidal. That's an interesting finding. But the plenum is broken and the meningoencephalocele is happening. And this is a site where meningoencephaloceles are not uncommon, being the high pressure in relation to the bigger cistern over there behind.
Okay.
And see, as you go behind, far behind from here, if I go, far behind is the carotid artery and bifurcation further there. That's the bifurcation of the carotid. That's the supraclinoid carotid where my cursor is. That's the cavernous carotid. And see, this is anterior to the area of the carotid artery. Now, if I reconstruct in all three planes, this MRI, if I reconstruct, since it is drive image, can be reconstructed. And if you see the site of defect in the coronal section, in the sagittal section now, can you see this?
Yes.
So this is the sphenoid dematization behind. That's the sphenoid behind. And this is a defect, you can say almost a centimeter or so. We can measure this. That's a defect, you can say. More than a centimeter you can see. Can you see
Yes.
in anteroposterior plane?
Yes.
More than a centimeter size defect in the plenum sphenoidal. Now, defects in various regions have various implications. Plenum defects are associated with the bigger cistern behind. So you have to be more careful, more secure in your closure. And a vascularized flap is always preferred over non-vascularized tissue in defects in this region. Because the bigger cistern is behind, the pressure behind is much higher than a pressure in a non-cistern area. And you have to be more, vigilant in sealing those defects. And vascularized flap is the final answer. So for this flap, we'll plan from beginning a vascularized flap or a Haddad flap from the beginning. We will not need a bigger hadad as the area is very close to the pivot point of the vessel where the flap rotates. That is the reason. See this. That is the reason of the nasoseptal artery.
Okay.
So, and you have to apply the flap right over there. So, we will not need a bigger flap raising from the right anterior part, right from the anterior nair, will not need such a bigger flap. So, this will not be a classical hadad, but some, minor changes with a lesser, size of the hadad flap will be required. But definitely a vascularized flap is required. Now, when it comes to order imaging for CSF rhinorrhea, this drive image is a preferred image. This is nothing but a heavily T2 weighted image, which can be reconstructed in all three planes. A simple T2 cannot be reconstructed. That has to be shot separately in all planes. But this drive image is a fine section, see 1.2 mm. So you don't do anything and you can reconstruct in all planes. So this is the one preferred image once you think of, ordering imaging for a suspected CSF rhinorrhea. And the second image, which is I always emphasize, is the 3D flare image. That is very important. You know what happens sometimes? Associated sinusitis is not uncommon. Sometimes you have a bony dehiscence and associated sinusitis, which may appear bright on this image as well. On T2 drive, every fluid will appear bright. Hello?
Yes.
On this drive sequence, T2 weighted imaging, every fluid sequence will appear bright, irrespective of whether it is CSF or sinusitis.
Okay.
If you have 3D flare image, 3D flare is inverse imaging of T2. Inverse means the CSF will appear dark, but the sinusitis will appear bright.
Okay.
On T2 weighted, everything, every fluid, irrespective of the content, it appears bright. So on 3D, had I been having 3D flare together, we would get to know what exactly this fluid intensity means. If it is dark, then it is CSF. If it is bright, then it is sinusitis. And sometimes it is very important in differentiation, particularly when you have a high suspicion of a CSF leak and patient may be having some associated sinusitis,
Okay.
which is not uncommon. So on the basis of drive or T2 weighted imaging, we should not reach to a conclusion, to a sort of 100% conclusion that it is sinusitis only. Though in this case, the diagnosis is straightforward. There is a history of trauma and you can see the brain contents are in continuity down in the this pocket in continuity from the brain tissue. So this is definitely a meningoencephalocele with no, question on the diagnosis. But what I'm saying, in a situation of doubtful diagnosis, suspected CSF rhinorrhea, we must have 3D flare together to differentiate any sinusitis from the CSF.
Okay.
I hope it is understood by everybody
Yes.
what I'm trying to say. So 3D dive and flare are two sequences which are very, very important for the CSF rhinorrhea diagnosis and differential diagnosis. Second is regarding the planning. See, this is the ideal case for endoscopic closure, and for that matter, any CSF leak at the skull base can be dealt with endoscopically if it is coming from the in the sagittal plane or even in the coronal plane. For such lesion with coming from the planum, defect in the planum, vascularized flap is always a good choice, or I would strongly recommend a vascularized flap in all the situations to prevent to get a good seal. And for a vascularized flap to be elevated, this hadad flap, the most important thing is, since we may have to widen the sphenoid opening like we do for the pituitary, we may have to widen to go around this defect for almost a centimeter and make the mucosal surface raw. In order to do that, we need a wider exposure. We may have to remove the rostrum and the part of the sphenoid wall to get a better exposure. And so as to prevent the damage to the feeding vessel of hadad, it is always better to raise the hadad first and do rest of the job later. So that the
Okay,
pedicle
sir.
is left undisturbed.
Sir, one question, sir. What is the
Yes.
relation of this defect to the optic nerve, sir? The relation of this
Optic
meningo.
now you can relate. See how to relate with the optic now. Though, uh, see this is the optic now. Can you see
Yes,
where my cursor is? Can you see my cursor
yes,
in the left side, in the left eye?
right, sir.
See my cursor is on the optic now. Follow this behind. Can you
Okay,
see?
yes,
See still my cursor is on optic now.
okay,
Cursor is on optic now, and this is the optic now. So this defect
fine,
is in very close proximity to the optic now on the left side.
right, sir.
Now see, come back. This is optic now. Can you see?
Yes, sir.
This is the globe from behind the optic now starts. I hope
Yeah.
it is very clear to everybody.
It's clear, sir.
So that is the value of dynamic imaging. That cannot be seen on printout. See this, follow this.
Yes,
See, this is 1.2 mm sequence. At our center, we get this drive imaging, MRI drive with 0.6 mm sections. So
okay,
you can, every move will go by 0.6 mm. Here we are going behind by 1.2 mm. Keep an eye on the optic now. See where my cursor is.
yes,
My cursor is following the optic now. Optic now. See this?
yes, sir.
Optic now. Optic now. Optic now. And see, this is
Chiasma.
the optic now forming the, going behind to form the chiasma.
Yes,
And see, that is the level of the, defect through which is in close proximity to the optic now. Where is, yeah, Narayan. Where is Prepa? Oh, come on. So, I have with me Dr. Narayan Jaishankar and Prepagaran. So, Pripa, any comments on the optic now? That is in close proximity to the defect. So, we have to stay more careful. I don't know the vision status of the patient.
If we can see the defect, you can see that although the encephalocele is quite large, you can actually trail it back all the way to the top to one small tiny defect, which is almost the midline.
Yes.
So as long as you remove the rostrum, like how you do a pituitary gland, and you bipolar and cauterize, it will take you straight to the small defect right in the midline. And the optic nerve will always, optical characteristic recess and optic nerve will always be to the back, to the side. In the sagittal cut, you can see there's a space between the encephalocele and the posterior aspect of the sphenoid sinus,
Yes.
which means the defect is actually more or less in the midline
Anterior.
with
more
nothing around it. So we should be okay. But it's a
Yes.
very good idea. You always make your enemies your friend. So in
Yes.
this idea, the sphenoid sinus, in this concept, your enemies are the dura, the orbit, and the optic nerve, and the carotid artery. So the optical carotid recess is always lateral and posterior. The brain, the dura, is always superior. So here we have an ideal situation where the defect is right in the center, in front of the sella, and away from the optical carotid recess. So your enemies are all identified, so you should be able to go to the lesion quite well. I pass it to Narayan.
Yeah, I think I agree with both of them. And as Satish has told you, one thing is we have a lot of people trying to just put fat in this defect and leave it. But as Satish has already told, this can be sometimes a little bit on a higher pressure side. So you better use a vascularized pedicle graft, especially if the defect is a little larger than you anticipate. Pure cribriform defects, you may or may not apply a vascularized pedicle flap. But once you're going towards a fovea, always make it a habit to seal it very nicely and use a pedicle flap. So it gives you an added healing and added sense of security.
Prabha, this defect is already more than a centimeter in size
Yeah.
in the anterior-posterior plane, and see in the coronal plane as well. The size of the defect is, more than a centimeter.
Yeah.
So that is interesting. In the anterior part of the planum, you have a defect of more than centimeter. This is the level of the rostrum. So this is more on the left side reaching the midline. But as I said, I need a raw surface all around for almost a centimeter for my seal to adhere, to make it raw, and my seal will adhere. So I will need a more exposure. So like Prepa said, I'll need exposure like we get for the pituitary.
Yeah.
I may have to remove the intersinus septum, the rostrum, the anterior wall I may have to lower down, and the lateral exposure till the lateral wall. So that I can see all around the defect for a centimeter, and all our enemies, like Prepa said, make your enemies your friend. So our optic nerve, carotid artery, all the way will be seen running in our field. So we can notice them, keep ourselves, away from those structures and do our job accordingly.
Yes, very nicely said. The other point is you will see that the majority of the time we spend is actually to give exposure. So we
Sir,
need to
your
find-
audio is not heard, sir. You're not getting your audio clearly, sir.
So both of them explain it very beautifully. I can't agree more. The other point you will find that the majority of the time we take is actually to give the exposure. We take almost 70% of the time to give the exposure, even in angiofibroma, even in most of these tumors. The approach and the exposure you have is extremely important. If you start plunging into the excision of a tumor or the lesion before you have an adequate exposure, when you have problems or you have bleeding or you have complication, then it's going to be very difficult to manage. So invest your time to get a proper exposure so that whatever complications that you may have, bleeding and whatsoever, becomes very easy. So I agree with them absolutely. We will need to do this exactly like how you do a craniopharyngioma or the pituitary gland.
Hello.
Yes, sir.
Yeah. Another thing to be seen when you, read the imaging for the CSF about the signs for the high intracranial pressure. Those patients, though this is straightforward traumatic, so it's not a big issue. Otherwise, in spontaneous leaks, mostly are associated with a high intracranial pressure, and that's how they present with leak as a rescue to release the intracranial pressure. So, as far as the signs of the intracranial pressures are concerned, see the most important, this optic nerve sheath. The optic nerve carries the sheath along till the disc, till the eyeball, and this contains all the meninges. If you have
Okay.
a high pressure, the disc is, engorged, and you will see the fluid around the optic nerve sheath. Dilated optic nerve sheath, you can say, with more fluid in the sheath around. Number one. Secondly, if it is more, it can press on the disc and you can see the flattening of the disc sometimes. Third is, on the sagittal plane, you can see sometimes, if you have a good, see, I don't have a good drive imaging. This is 1.2 mm, and see this, the sella is not completely replaced by the arachnoid pouch. Had there been more high pressure, this arachnoid would herniate more and more and replace the sella by means of pressing on the pituitary gland to push aside. So that is
Okay.
known as empty sella. But in
Okay.
this situation, I don't see very high pressure as such as a pathology in this patient. But since the defect is in relationship to a bigger cistern, it has led to the, herniation of all the brain contents as those pushed by the CSF pressure into the outside the cranial cavity. So this is a meningoencephalocele.